I will talk today about acne and microbiota, and it's interesting to have a look at what's new in acne and and microbiota. So, why acne? Acne, we see more than 50% of our patients in the clinic, in the private clinics especially, they have acne. And they have different grades of acne, as you see, from almost no lesions up to the very severe acne cases. What brings this severity? Why are some people having just few papules and others having nodulocystic lesions and scarring? All this is the interplay between the microbiota and the host immune response. And as you know, the acne main players are androgens and corticosteroids, locally produced in the skin, excessive sebum production, hyperkeratinization, release of inflammatory mediators into the skin, which are triggered by the microbiome dysbiosis. As Professor Luger has already mentioned, there are microbiomes in the skin which differ from different areas of the skin, of the body. The moist areas show different microbiota than the greasy areas, than the dry areas like the hands. Every part of the body has a different microbiome system. And we're focusing today about the sebaceous areas which have mainly Propionibacterium acnes, now known as Cutibacterium acnes. So, Cutibacterium acnes, previously known as Propionibacterium acnes, accounts for up to 90% of the microbiota in sebum-rich sites. And the abundance of Cutibacterium acnes also changes with age, being very low in children, becoming the highest during puberty and adolescent life, and then decreasing gradually and, until the age of 50, where they disappear or become very little. Cutibacterium acnes is primarily known as a beneficial commensal. It helps maintaining the low pH of the skin by releasing free fatty acids, and it blocks pathogens like Staph aureus and Streptococcus from colonizing the skin. However, we all know that Cutibacterium acnes has a role in acne pathogenesis. So, do Cutibacterium acnes differ in number or in type between acne-prone and non-acne-prone patients? Well, actually, studies have shown that Cutibacterium acnes in amount are the same in acne subjects and healthy subjects. But the difference lies in their phenotyping. So there are different ways of typing of the bacteria nowadays, including DNA and ribosomal categorization. And there are main phenotypes, which are 1, 2, and 3 for Cutibacterium acnes. Type 1A1 and 1A2 have a role in acne, especially 1A2 is very closely related to severe types of acne. There are also 1B, 2, and 3, and 3 is interestingly present on the trunk and is responsible for the progressive macular hypomelanosis. This is a table that shows different typing methods, including the clade based on whole genome sequencing, clade based on the extended or expanded multi-locus sequence typing, and the ribotyping on the right side. And each one shows where the phenotypes that are responsible for acne are present. And as you can see that 1A2 is mainly present in acne-prone cases, and 1B1 is also present in acne-prone patients. In addition, there are some changes in other microbiota, not only increase in Cutibacterium acnes, but also Cutibacterium granulosum, Staph epidermidis is increased, Protibacteria and Firmicutes are increased in acne patients. There is a decrease in Actinobacteria, and there is a decrease in Streptococcus in pre-adolescent acne, and there is also an increase in the Malassezia species in the skin. While there is in the gut, there is increase in the bacteroids. What is the relation between the gut and the skin? It will come. It's worth mentioning that Staphylococcus epidermidis has an anti-inflammatory role in acne. It downregulates the pro-inflammatory cytokines that are produced or are triggered by the Cutibacterium acnes. So, in acne, there is no hyperproliferation, but there is an imbalance or a dysbiosis in the acne microflora and the microflora, with increase in the number of pro-pathological Cutibacterium acnes and a decrease in the benign types. So it's all about balance. There is no balance. Here it shows more closely. On the left-hand side, it's the good guys are the green ones. The good guys are more than the bad guys, or on the right side, the bad guys are more than the good guys, and hence acne is produced. So, Cutibacterium acnes phyllotypes are also related to the virulence, and there are inflammatory factors that are produced by the phyllotypes that produce acne, including neuraminidase, lipase, polyunsaturated fatty acid isomerase, iron acquisition protein, heat shock proteins, etc. And there are host interacting factors, including porphyrins, hemolysins, dermatan sulfate binding adhesins, etc. Porphyrins are virulence factors. They are virulence factors because they stimulate cytokines, they induce the production of acne lesions by multiple types. And there is, how can you know that there are a lot of acne that are producing porphyrins? By using Wood's light. And by Wood's light, the acne, the Propionibacterium acnes, the fluorescence orange, and the higher the amount of fluorescence, the more you can see that there are bad acne lesions or bad Cutibacterium acnes present in this site. So, it's not hyperproliferation. Again, it is a dysbiosis. Adding to it that some of the Cutibacterium acnes may produce a biofilm, and this biofilm increases the virulence and increases the resistance of the Cutibacterium acnes, and this entails more. I mean, there are the active, when you use antibiotics and the bacteria are producing biofilm, they do not function even if they are solely sensitive. When they are in a biofilm, they are protected and they don't respond to the antibiotics. So the interaction between skin microbiomes and the host immunity plays an important role in acne, with perturbed microbiome composition and activity found in acne patients. So the other question is, we see patients with adult onset acne, ladies above 25 years of age with adult acne, and we already know that acne usually affects adolescents. Is there a difference in the microbiota of adolescents versus adult acne? Well, studies have shown that women with adult acne do not differ in their microbiome composition compared to the adolescent acne. So not only Corynebacterium acnes are affected by antibiotics when we use them for a long time, the antibiotic resistance can be transferred to other neighboring organisms like Staph epidermidis, and we have seen that 30% of Staph epidermidis isolated from skin with acne were resistant to drugs used in acne treatment like clindamycin, erythromycin, etc. Topical antibiotics, therefore, should be combined always with retinoids and benzoyl peroxide to lessen the risk of antimicrobial resistance. And for maintenance in acne, topical retinoids or azelaic acid will maintain a good microbiome or microbiota in the skin. And again, systemic antibiotics also should be combined with topical retinoids and benzoyl peroxide or azelaic acid in order to minimize the antibiotic-resistant Cutibacterium acnes. So, what's new in acne? The impact of acne treatment on skin bacterial microbiota. Now, people are thinking of diminishing using systemic antibiotics for decreasing the resistant strains and interference in microbial structure signature of acne microbe and microbiome. And there is also the mask acne, which has emerged with the extensive use of masks during the COVID era. And there was a real change in the microbiota in the area which is where the masks were used. There is increased humidity, there is increased friction, and the types of Cutibacterium acnes have also changed. Now, gut microbiota and skin microbiota, is there a relationship? Do the people who have acne have any problems in their gut microbiota? Yes, they do. And it has been shown that stresses will interfere with the gut microbiota, and these gut microbiota have also a relationship with the skin microbiota by more inflammatory mediators and emphasizing acne in all those patients. So there is now what is known the gut-brain-skin loop that has a role in acne. And previously, as we were very young, when somebody got pimples on his face or inflammatory papules on his face, they told him, you have something bad in your stomach, go and fast or change the diet. And this is true because the Western diet, full of carbs and polysaturated fatty acids, it has shown that it increases the acne by stimulating insulin-like growth factors and insulin, in addition to changing the microbiota. So, what could help? Oral and topical probiotics may help in acne treatment, and there are a lot of probiotics that are now available on the shelf in many supermarkets, even in the States and in Europe, that provide people with probiotics to treat different types of diseases, including acne. And as you can see here, Staph epidermidis, Streptococcal salivarius, Lactococcus, etc., Lactobacillus, Enterococcus, Lactobacillus plantarum, there are all probiotics that can be used orally or topically in the treatment of acne. So in conclusion, Cutibacterium acnes phyllotype imbalance is responsible for acne. Bacterial resistance to antibiotics keeps rising, so we have to change the use of antibiotics as an anti-inflammatory in acne. And targeted therapies to vicious phyllotypes are underway, as Professor Luger has mentioned, using the fecal transplants or using of probiotics, etc. And probiotics may be of help in acne, and the role of gut microbiome and its relation to stress and acne, the gut-brain-skin axis in acne is in focus and may provide additional therapies in the future. Thank you very much.
Thank you, Professor Marwa Abdallah, for this
you.
comprehensive lecture about acne and microbiome. أستاذ دكتور مجدي اتفضل يا بيه.
بلاش.
Thank you, Professor Marwa. يعني أنا بعبر عن إعجابي as usual. محاضرة ممتازة جدا جدا. أنا شخصيا اتعلمت منها حتة الفيرولنس اللي هي بتتحكم، إنما الكيوتي بكتيريا موجودة عند الناس كلها، إنما الفيرولنس وطلعت ال 1A2 هو ده المسؤول السترين ده عن الأكني. ده كلام جميل، بس المحير جدا ليا ومانيش فاهمه. I can't understand and can't get it up. What is the cause of this 1A2 to be there, and what is the cause of formation of biofilm which makes the acne resistant to bacteria? Is there any genetic background, a genetic factor behind this? I don't know.
Probably yes. The answer is probably yes, because it is. They have found that in some people the bad phenotypes take over, and there must be some host factors that increase the bad phenotypes and induce acne. And you can see it also in families, running in families with severe acne. It is transmissible. So probably yes, host factors always play a role, and genetic factors always play a role in all diseases that we are encountered.
Okay. Thank you very much.
Thank you.
مروه كان في سنتنس كده كاتباها ان resistance واحد من الكوراني بكتيريوم could be transferred to antibiotic to be transferred to another species.
Yes, there is a transverse transmission of resistance factors, ribosomal and phage type resistance can be transferred from the Corynebacteria to the neighboring bacteria present. And Staph epidermidis is the closest bacteria that is always present with Propionibacterium or Cutibacterium acnes. So that's why the Cutibacterium acnes can transfer this resistance to the neighboring, and hence you have a lot of resistant bacteria which are not maybe also to Staph aureus, etc., which may be of a major problem in the future.
Yes, it is. Okay, شكرا. دكتور ماجد اتفضل.
اتفضل يا باشا. شكرا جزيلا دكتوره مروه، شكرا دكتور هشام زاهر، استاذنا دكتور مجدي بيه. ودلوقتي هنبدا السيشن الرابعه، وهنسعد بالتوكس دكتوره دينا درغام، استاذ مساعد الجلديه في القصر العيني. اهلا يا دينا. هتكلمنا على افوكس اون سكين بوست اكني تريتمنت.
مساء الخير. مساء الخير دكتور نجوى، مساء الخير دكتور ماجد. Good evening, Professor Logan. Thank you so much for your interesting lecture. It was such an experience attending a lecture for you.